Good afternoon, everybody. My talk is almost the repetition of the previous talk. I'll summarize it. First of all, I want to know how many are using IOL Master. Thank you. So I come to know the entire state is having only 10 IOL Master machines. That's why whether I have to spend more time on the scans or the IOL Master. So I'll summarize the Dr. Natarajan talk. I have no financial interest in these instruments. So the difference of these three scans, supplementation and immersion and non-contact. So the characteristics, as he has already described, 5 high amplitude spikes, steep 90-degree raising retinal spike, separate retinal and scleral spike. In the immersion scan, note that there is an extra spike due to the probe. The effect of corneal compression in this example is the anterior chamber depth in the first scan of the same eye is 3.20, in the second scan 2.63, which indicates this in the second scan there is a compression of the cornea resulting in erroneous axial length. So this is the advantage of this is not only non-contact, when you align the shell, the visual axis alignment is easier. So the ideal immersion scan indicates 2 corneal spikes, one from the epithelium, another from the endothelium of equal height. Note down that the length is 0.1 to 0.3 mm more than that of the contact scan. The advantages is already described. So the amplitude of the scan depends on the density, angle of incidence and the interface. We cannot change the density or the interface of the eye. There is a chance to change the angle of incidence. If the angle of incidence is parallel and coaxial, you get the high amplitude scans. If it is oblique, you get low amplitude scans. In a retinal pathology, because of the curvature, if it is a convex due to macular edema, irregular due to macular degeneration, you get low amplitude spikes. Gain is, how much gain we have to keep in the scan is, when you get retinal and scleral spikes, that is ideal for that particular eye, for that particular scan. You may require to increase the gain in nuclear cataract. You have to decrease the gain in the absence of the lens. So the effect of the gain in this scan is there is a loss of the scleral spike due to excessive gain. The velocity of the sound in the liquids and the solid vary. In the variation in the eye is the lens. In one particular eye, the lens thickness is as small as 2 millimeters. In one particular nuclear cataract, as high as 7 millimeters. Because of this variation of the lens, there is a very chance to get the wrong readings with the same mode. In that, if you think that it is necessary and the highly thick lens, you cut into a gate system where you cut this into 3 compartments, anterior chamber, lens and the vitreous chamber, measure individually, add for the total length, you get the accuracy. So every time it is difficult, we made into averages. Phakic average is 1550 meters, aphakic average is 1532 meters, pseudophakic is 1532 plus correcting factor for that particular IOL like PMMA, silicon or acrylate. Whether to take manual modes or auto modes. Generally we prefer auto mode where it takes 5 or 10 readings automatically, whereas in manual 1 at a time. If you are not getting clear scans with auto mode, we switch on to manual modes. In manual mode, select the ideal scan and calculate. In auto mode, select the ideal scan and delete the bad scans. So whenever you do the scans, you should remember the averages. The normal, the normal average is 23.5. The anterior chamber lens average 3.2. Lens is 4.63. Average K is 42 to 44. So whenever you take the thing, verify with pre-cataract refraction whether patient is myopic or hyperopic. The axial length should be 0.3 mm with the other eye. There may be difference in the pathological conditions. In posterior staphylomas, it is difficult to get a correct A scans where you have to rely or combine with A and B scans or IOL master. This is a misaligned scan where the scan is going to the optic nerve and results in absence of the scleral spike. Another misaligned scan diagnosed by the retinal spike is not 90 degrees to the baseline. The other misaligned scan where the posterior lens spike is not as anterior lens spike. So there are artifacts in the presence of IOL where you get a lot of disturbance with PMMA lens and less disturbance with the foldable. Coming to the second part of my talk, the IOL master. The advantage is non-contact, fast, increased accuracy. A single instrument will measure both K, ACD and axial length, and you can personalize your own lens constant by measuring 20 or 30 of your own surgeries with a particular lens. So you can alter the lens constant. So this is especially useful in staphylomatous eyes, high myopia, silicon field eyes, post-refractive surgery. The disadvantage with IOL master is dense cataract, PCO, nystagmus, poor fixation. So to start with IOL master, you have to calibrate the instrument every day morning. Then the ideal readings are depending on the wave pattern, signal noise ratio, this traffic light signal where the instrument depicts a green signal gives an ideal. This is how we focus, where the sharp focus is in the center, which is verified by a vertical thin line. So the signal pattern, if you take single readings, it will be in the red color. If you take a composite reading, like 5 readings, you get a blue signal. So on the in the composite signal, verify whether all are within the things. For example, in this, the right eye reading shows on the left side of the screen where they are almost 23.10. So the signal noise ratio, the mission will show the green means the SNR value more than 2, yellow means SNR 1.6 to 2, the red means SNR less than 1.6, which shows the error. So the ideal pattern is one long peak on either side as 2 small secondary waves. The peak, remember, it is from the retinal pigment epithelium. So the medium noise and the high noise you see when there is a dense cataract, when the patient is not cooperative, when the patient is high emetropia, so you get this type of pictures. So sometimes the mission shows multiple spikes. So multiple spikes indicates there is some disturbance. So in that, magnify the spike and see whether the cursor or the signal is on the left side of the peak, on the right side of the peak. So majority of the pathologies are in front of the retinal pigment epithelium. That's why you believe when it is on the right side. If it is on the left side, clinically verify, and if necessary, move the cursor to the right side and measure it accurately. For example, a patient with IOL, we want to take the reading. The upper 2 readings are false. The lower 2 readings are correct. So even though it is a false reading, the spike due to IOL is taller. False spike is taller than the true spike, where it is showing as 18.97, which is a false reading. Whereas in the lower part, the false reading is smaller than the true reading, true spike, where it is measuring as 23.42. Like that, say for example, another example is epiretinal membrane. In epiretinal membrane, you get a spike from the membrane, you get a spike from the pigment epithelium. You may be surprised to see the membrane spike is taller than that of the pigment epithelial spike. So in a case of K reading taking, all the 6, when compared to the manual, we take only 2 spots, whereas in the IOL master there are 6 spots. So you see that they are small, sharp, and a signal, traffic light signal is green. So whenever it is defocused, consider the pathological conditions of the cornea. Commonest is the dry cornea. When it's dry, ask the patient to blink more number of times. If still it is showing, you can put artificial tears. Remember, the corneal scars, keratoconus, and pathological conditions also gives improper readings on the cornea. So there are some exceptions and additions to whenever you take the IOL master reading. If the reading is too short, less than 22, you repeat with the immersion scan. If they both are showing lower than 22, then you can consider it is correct. If it is more than 30, it is a long eye. It may be associated with posterior staphylomas. Confirm with A and B scans. If it is a OD and OS difference is more than 3.3, MD means the doctor, you have to confirm whether it is there or not. The astigmatism more than 3.5, you may be dealing ectatic conditions of the cornea like keratoconus or pellucid marginal degeneration. If the average K difference is 0.9 more, the doctor who has to confirm it whether it is any pathological condition. If the average K is steeper or flatter, you have to confirm it clinically. If the ACD is too shallow or too deep, you repeat with immersion scan, verify the findings. If the white to white is too small or too large, is the doctor who has to certify it. Thank you for your patience.